there are what I would consider to be 4 problems that you have to deal with when deciding what to place and how to place it. Number 1, you've got the tooth. How much tooth structure is there that you get to deal with? How much you take away to remove the pathology determines what you might place. So to some extent, your diagnostic capabilities of finding things earlier, your capabilities to be minimally invasive and clever as far as how you remove tooth structure to access pathology, as opposed to just, obliterating a bunch of tooth structure. From there, after, deciding how we're going to access the tooth and how much tooth we have left, the next thing is looking at the substrate. Is what type of tooth do I now have available to grab onto? Am I grabbing onto enamel mostly? Am I grabbing superficial dentin? Am I grabbing middle dentin, deep dentin, sclerotic dentin? Like all of those things play a role in potential longevity of a restorative material, as well as postoperative sensitivity and potential microleakage and future problems for that patient. So we're thinking about that. So preparation design comes into play as far as, like I said earlier, access of pathology, but also preparation design comes into play as far as the type of material you have and tools you have to access something and place something. So sometimes we need to expand a tooth, let's say to place a matrix band or to get the tip of an instrument in for, placing restorative material. So the preparation becomes quite critical to the process as well. So you're thinking about all 3 of these things while you're, working up the case as well as working on the case. And this changes as we're moving through the process of removing pathology, such that what we thought we were going to use, sometimes it's going to change and shift based on what we find as we open things up. Now, the last thing that I'm going to consider would be the occlusion. What is the forces that are going to be impinging upon whatever restorative material I select? Is that material going to be strong enough to withstand occlusal loading in someone that has maybe more of a plunger cusp or a pointy prominent cusp? Or is it someone that's ground their teeth and everything's fairly flat, so there's nothing necessarily impinging down into the material, but there's still a lot of pressure just going into the tooth itself? So more of like compressive strengths rather than fracture toughness. And in generalities, we have glass ionomers, or I should say conventional glass ionomers that are self-hardening. We have resin-modified glass ionomers, which self-harden as well as being able to be light cured because of the resin chemistry within them also. From there, we also have flowable composites, been around for a long time. We have newer injectable composites. We then have our bulk fill composites, which is kind of the lion's share of the market these days. And then we also have packable composites that have been around forever, but keep improving as far as the chemistry behind them. And if you think of the bioactivity of a glass ionomer and its ability to release calcium phosphate ions into the tooth to strengthen the tooth, and it actually creates stronger dentin, which we call an intermediate layer or an interdiffusion zone. This stronger dentin, just by having touched glass ionomer, gives us a huge insurance benefit over time. So where we have deep dentin exposed close to the pulpal tissues, maybe if we're trying to work quickly, a bulk of glass ionomer as a dentin replacement, because it has a compressive strength similar to dentin if we're talking about conventional glass ionomers. So a conventional glass ionomer being 233 to 250, dentin being about 280 to 297. Conventional glass ionomer is very similar as compared to a resin modified glass ionomer, which is a little bit lower potentially. Okay, and enamel being higher. So maybe not the best for an enamel replacement in some cases, but definitely a good product for the dentin. Minimally invasive dentistry such as this, placing runny enough materials that get into these little holes, is something like flowable composites we've had around for many years. But most of us would think of flowable composites as not being very durable, especially in someone who has high wear or a plunger cusp coming against it. And so we think it's not going to last as well. And so we might think, well, then I need to move to some other type of traditional composite, maybe like a nanohybrid in a compule or a syringe. But technology has improved in such a way that we now have what we're calling injectable composites. Injectable because they have the same characteristics as the pastes we're used to using, but injectable in the sense that they are runny enough to flow and adapt easily like a flowable would. But nowadays, I mentioned there's also injectable composites. So where you have GC's newer genial bulk injectables, I could fill this whole defect with an injectable composite that has the same physical properties as paste systems. So that's a great option nowadays that I'm using quite regularly. GC found a way to create what they're calling this FSC technology, this full coverage silane coating, to get more thorough, more complete coating of their particles, their filler particles within the matrix. And by doing so, they get better coupling and adaptation between particles, which derives better strength, as well as better, characteristics as far as wear and strength and polishability. You'll notice here that we have 3 different walls. We have the axial wall, the pulpal floor, and another axial wall in the case of filling this defect here, let's say. In doing so, I've got a C factor of 3. This little box, if we extrapolate, you'll see it here. As soon as I go up the axial wall, I've added in additional C factors. I've created more stress and more problem on my margin. So if it's interproximally, it's going to lift down here, in the pulpal tissue, the gingival box area. And by doing so, I have more risk of leakage over time and future decay. So if I'm going to place a first increment down here, as I mentioned earlier, you want to put it just on the floor. Okay? You don't want to go up the axial wall. So this red line is saying, hey, stop here, don't turn the corner. Because when you turn the corner, you create problems for yourself and the patient. And so in looking here, C factor, the definition of it is basically the ratio of bonded to unbonded free surfaces. That micro gap may not seem like much, but you look at it on a big SEM, it's significant. Okay? So that first increment that I'm talking about placing with potentially like this bulk injectable just on that floor is critical. Now from there, I personally am still a fan of placing some different increments and slowly incrementally build. So I'm typically placing this bulk injectable just on that floor and maybe going back and adding a little increment on maybe an axial wall on the pulpal or the gingival floor, and then a little bit on the other axial wall on the gingival floor. And so I built it up a little bit with the least amount of C factor, and then I'll go in with some warm composite on top. And that allows me with that warm composite to then manipulate it and create that beautiful anatomy that we all enjoy placing in our composites. Right? So by the time I get done curing this, I've got something that's pretty solid.